My name is Professor Siobhan Quemby. I'm Professor of Obstetrics at the University of Warwick and Honorary Consultant at University Hospitals Coventry and Warwickshire NHS Trust. I'm going to finish this conference by trying to explain to you how far we've got with recurrent miscarriage research and what is the future. So I'm going to go over what do we need to do to prevent miscarriage. I'm going to try and expound to you and encourage you to think of the concept of personalised care. That means giving the right care to the right patient according to their history and test results. I want you to try and think of miscarriage as an opportunity to offer the patient preconceptual care. And for those people who excellent preconceptual care still leads to further miscarriages, I'm going to suggest to you the future will be an endometrial test that determines future treatment pathways. There's two endometrial tests I'm going to talk about. One you've just heard about, that to detect excessive senescence or stem cells deficiency, and the other one to detect a condition called chronic endometritis. So first of all, how are we going to personalize care? Well, we need to personalize care by things that we already know. So we know that age is very important in predicting miscarriage, and there's a J-shaped relationship between age and future miscarriage risk. So that if you're very young, you have an increased risk of miscarriage, and also if you're over 40, you have a significant increased risk of miscarriage. The other thing that we know that's very important in determining miscarriage risk is the number of previous miscarriages. So we know there's a stepwise increase in your miscarriage risk with each miscarriage. So if you've had no previous miscarriages, you have 11% chance of miscarrying in pregnancy. If you have one previous miscarriage, that goes up to 20%, two previous miscarriages, 28%, and three previous miscarriages, 42%. So one way of personalising care is by number of previous miscarriages. And that's something that we've expounded in our recent Lancet series. So we say that one previous miscarriage, remember that increases your risk of miscarriage from 11% to 20%, does deserve some care. The care that should happen is basic preconceptual advice. So that means if you've got a raised BMI, to be directed to weight loss services, to get any comorbidities optimized. So asthma, hypertension, diabetes, epilepsy should all be optimized. Two previous miscarriages, perhaps you should have some blood tests, definitely thyroid hormone or TSH test, a very cheap, easy test to do, and possibly antiphospholipid syndrome. If you've had three previous miscarriages, then you should have more tests. So we've just done this suggestion of personalizing care on the basis of number of miscarriages, but clearly she would also personalize on age. So if someone's over 40 and they've miscarried, it may well be it was because the pregnancy was aneuploidy, but some people over 40 miscarry normal pregnancies. Hence, every effort should be made to make sure the next pregnancy is successful. So what happens if you do that? Well, you've just heard some very good data from Rebecca Shields, and I'm just going to show you again, make no apologies for that, to point out that if your body mass index is less than 30, and you conceive, in fact, nearly everyone goes on to have a live birth. So that's something we should all be working hard to sort out. Also notice that if you've had 1, 2, or 3 previous miscarriages, nearly everyone who conceives ends up with a live birth after a couple of years in our care. Those people need a lot of support. However, the people who have more than 3 previous miscarriages, despite excessive support in my clinic, still continue to miscarry. You can see there's a gap between the blue and the green lines. So those are the people that we need to find new treatments and to prevent miscarriage. So what new treatments are we going to think about for those people? Well, I think it's now clear that those people should have treatments based on the lining of the womb. So in these conferences over the years, you've heard a lot about NK cells, and we've actually found, been able to look at the endometrium in people who lose normal pregnancies compared with those who lose abnormal pregnancies, that's mainly trisomies, and compare that with the NK levels of people who have live birth. You can see the first problem, there's a massive overlap between these patients, so a single test result's not all that helpful, but the people who lose normal miscarriages has a significantly lower NK result than those who lose abnormal pregnancies or live births. If you then add that finding to the test that Joe Mutter has helpfully described to you, the test for excessive senescence, we found that if you add the excessive senescence to the N cases deficiency, you actually get far more of those who lose normal pregnancies, whereas those who lose abnormal pregnancies or live births are more or less the same. So look at this, it's looking like we're going to have a test that tells us who needs some treatment to prevent the loss of a normal pregnancy. And what are we going to do with that test result? Well, previously we did a thing called the SimPlant trial, and here we randomized people to sitagliptin or placebo for 3 months. And our primary outcome measure was clonogenic assays, or the number of colonies. This is a marker of your endometrial mesenchymal stem cells. We found that sitagliptin significantly increased your endometrial mesenchymal stem cells and significantly reduced your number of senescent cells. However, that was only a small study. It only had about 35 to 40 people in it, so it wasn't significant to change clinical practice. So the answer to that is that we need a large-scale randomized controlled trial with good clinical outpoints. But what trials are going on at the moment? Well, at the moment, the most commonly researched topic in this area is a thing called chronic endometritis. Chronic endometritis is persistent inflammation in the endometrium, and it was originally described as an infiltration of plasma cells seen on hematoxylin eosin staining. So this was a pathologist looking at a slide and saying, I think I can see more plasma cells than I should. They didn't quantify the cells, and it was a pathological opinion as opposed to a repeatable diagnosis. This is asymptomatic endometritis. This isn't the endometritis you get after you have a baby, when you have the classic signs of infection, bleeding, and pain. This is no symptoms, just silent inflammation. It's been associated with recurrent miscarriage, implantation failure, infertility. The problem is there's no gold standard for diagnosis. And the most commonly used method at the moment is to use CD138 to highlight the plasma cells or the positive cells. There's lots of small studies showing an association between chronic endometritis and miscarriage. There's never been a randomized controlled trial. These studies are all non-randomized. So this is what chronic endometritis looks like down the microscope. The brown staining is cells that have stained positively for CD138. You can see this patient has a very high level, and this patient, there's only a few brown cells, and this patient has a mild level of chronic endometritis. So just to show you how much confusion at this topic, I'm now going to show you some results of a systematic review done by excellent research fellow Josh Adental. Here, he looked at the techniques used to diagnose chronic endometritis, and you can see there's lots of different techniques, including H&E, hysteroscopy, CD138, and culturing the endometrium. And look at the massive difference in results. There's a massive change in the prevalence by diagnostic type, whether you use hematoxylin eosin, immunohistochemistry, hysteroscopy, or endometrial cultures. If you look at it by condition, again, you get this massive scatter of results. Whether you look at it in recurrent implantation failure, infertility, recurrent pregnancy loss, mixed gynecological or mixed reproductive conditions, you have a huge scatter in the prevalence of this condition. Clearly not much agreement between sites. So we have been looking at using a CD138 immunohistochemistry. 24 studies of this was identified, but there's often a lack of important variables in the reports. So method of qualification was sometimes not stated. The diagnostic threshold, how many positive cells did you have to have in those pictures I showed you to count as chronic endometritis? That varied hugely from 0.25 to 5 per high power field, and quite often not even stated. Also, the timing of the biopsy, whether you did it in the proliferative or the luteal phase, was sometimes not stated and did seem to have an effect on the results. But what there was a bit of a consistency of is that if you had chronic endometritis, you were less likely to implant after IVF, you were less likely to have a clinical pregnancy, and you were more likely to miscarry. You're also less likely to have a live birth. So we have a consistency in the outcome, but a massive variation in diagnosis. I'm just going to show you why that happens in more detail. So we have noticed two types of staining with CD138, this kind of diffuse staining here, and this other which you can see this sort of brown smudge. And this other thing, which we've called punctate staining, which is kind of more of a circle or a fried egg appearance. Now, this fried egg appearance looks more like plasma cells stained with CD19 or CD56 or NK cells. So we think these are more immune-like cells, and these are more like inflamed stromal cells. We then compared the CD138 with the NK percentile. So you can see people with very high numbers of brown smudges had very low NK cells, and people with this punctate staining had high levels of NK cells. So this is work done by Rebecca Sweetman as part of her master's degree in the University of Warwick. She's also compared the severity of staining, CE staining, with the pattern. So people who had very high levels of staining had lots of this diffuse, whereas people with only mild levels had more of the punctate methods. Another way of looking for plasma cells is to stain it for CD19. And here you can see that the people who had the punctate staining had more CD19 cells. So we think we have discovered two different types of chronic endometritis. One has the high CD138 diffuse low NK cells, and this represents low decidralization, failure to clear senescent cells. The second one had the high CD138 punctate, high CD19 cells, and this seems to look more like an immune reaction to infection, stromal inflammation, and less favorable environment. So this all matters because of the excellent work done up by colleagues in Peel College, and they have found by looking at swabs of people before they miscarry that miscarriage is associated with a different microbiome. Miscarriage is associated with depletion in your lactobacilli. So lactobacilli are bacilli who should be in the vagina, and they should be there. And we think that if you have a reduction of that and a lot of different kinds of bacteria, then you have a lactobacillus deplete state, and this lactobacillus deplete state has been associated with miscarriage. So the big question is, which kind of endometritis has the abnormal microbiome? That's something we're going to be able to answer with a SERM trial. There have been all sorts of non-randomized studies suggesting that antibiotics are helpful in people with chronic endometritis. But these are non-randomized, and they're quite odd because, look, they've compared persistent compared to resolved CE. So if the chronic endometritis disappears, your miscarriage rate gets better, no randomization whatsoever. And the live birth rate of CE is comparable to the live birth rate in treated CE is comparable to live birth rate in women without CE, but there's no live birth rate in people that are randomized to the placebo, except for our pilot data for our grant. So no randomized data. We don't know how much this CE persists, how it's related to lactobacilli, and whether or not it will get better with doxycycline. These are all critical treatments, critical questions, and we're going to answer them all with this SERM trial. So the SERM trial is an adaptive design trial where we're recruiting people with 2 or more recurrent miscarriages who have high levels of CD138, both types of staining. Our intervention is doxycycline 100 milligrams for 14 days, and our comparator identical placebo tablets. We have 2 primary outcome measures. One is an ongoing pregnancy rate at 12 weeks. That's to help us get results more quickly to work out whether it's a good idea to carry on with the trial. And the second one is the live birth rate. So in conclusion, the future of miscarriage care is to personalize care. You can all personalize care today. You can personalize care from everyone you see on the number of miscarriages. Every miscarriage matters. Everybody needs some treatment. After one miscarriage, you need to optimize your lifestyle, stop smoking, optimize your BMI, sort out comorbidities, and have the necessary support for the mental health mobility associated with miscarriage. We need to be aware, and people need to be aware of the very strong relationship between age and miscarriage, so that they're mentally prepared for their own miscarriage risk, and we can do as much avoiding action as possible. The future will be the endometrium. The future is going to be take a test of the endometrium, find out if there's a problem. If you have this pro-senescent endometrium, this exciting science that you've heard from Joe Mutter, there isn't a treatment yet, but we will need to be able to do a randomized control trial in the future to find a treatment. and that will be the entry criteria for the trial. If you want to be part of this resolution, please join our SERM trial. We are desperate for new sites. If you join our SERM trial, your patients will be able to have an endometrial biopsy. Your patients will be known whether they've got chronic endometritis, and your patients will have the opportunity to be randomized to doxycycline or placebo. If anyone's interested in joining this trial, please either email myself or serm@warwick.ac.uk. So thank you very much for listening. Thank you very much for your contribution to the Association of Early Pregnancy Units. It's a really active society. We've made massive difference in research between us. I hope you've enjoyed the meeting. And I'd particularly like to thank all the people who work in the Warwick team, the Tommy's charity, the hospital, the funders, that's the NIHR and the MRC, and my fantastic reproductive health research unit. So the work I've shown you today has been done by Joshua Dental, Amelia Hawkes, Rebecca Shields, Comel particularly, and Joanne Butter, you've heard speak herself, and Rebecca Sweetman. Have you got any questions?